చూడండి. తిరిగి 11 స్టార్ట్ చేద్దాము. అందరికి 11 చేసిందా? అదే మా వాళ్ళందరూ 11 కల్లా ఉండమన్నాను, చెక్ చేసుకుని ఇచ్చేస్తాం. థ్యాంక్ యూ. రెస్పాన్స్ ఇచ్చారమ్మా ఎవరైనా? అది కాదు, ఎవరైనా అందరూ వచ్చారు వచ్చినట్టుగా అది తెలియదు కదా వాళ్ళు ఇచ్చేవారు నాకు. రెడీ అమ్మా? ఎనీ రెస్పాన్స్? 1 minute ఉంది. Please respond and wait for the message. If you are ready, please. నా పెన్ డ్రైవర్ మరి వాళ్ళని అడుగు, ఇక్కడేం లేకుండా మరి వాళ్ళని అడుగు. అక్కడ ఆ రూమ్లో ఉంటారు కదా, నాదే పెట్టాడు ఇప్పటిదాకా. అయితే వాళ్ళు ఏమో తీసి పెట్టారమ్మ. మీ బ్యాచ్ వాళ్ళు ఎవరైనా ఉన్నారా? వచ్చారా? అందరు వచ్చారా? వీళ్ళ బ్యాచ్ ఎలా తెలుసుకున్నాను? సరే వాళ్ళు వచ్చాను చెప్పాను. మీ బ్యాచ్ వాళ్ళందరూ వచ్చారు. Is it live now? Good. Good morning everyone, both the senior batch and the junior batch. Let's continue with our classes. Our aim is to conduct about 25 classes, 25 lectures each, 25 by me, RK sir and also Varprasad sir. So then once the things become better, the senior batches will be presenting the seminars and also the second years, so that you get more capacity to teach. Today's topic, actually I am choosing such topics which are not dealt with by most teachers. One of them is anesthesia for cardiac catheterization. Why is that important for us? So the cardiac procedures are increasing day by day and many interventions are done also. So most of the times anesthesia is always there as a standby, because anything can go wrong. Anything can go wrong during cardiac catheterization. So when we were all students, we used to have a regular posting in cardiac. It's a challenging one. So I will tell you what are the issues related to that one. And for the junior batch, please listen to it. So you will understand the way the lectures are given or the seminars are conducted, and so progressively, one after another, all the topics will be covered. For example, if you take respiratory physiology, there are 5 issues. Entire respiratory system depends on volume, pressure, flow, resistance and compliance. Whether you go to the ventilator therapy or your anatomy and your anesthetic management, everything, the graphics, ventilator graphics, everything depends on these 5 factors: volumes, pressures, flow, resistance and compliance. So we will be dealing one after another. One of the senior students wanted a class on the compliance and all, but I am just compliance and the time constants, etc. I will deal with them. If I can see your reaction, how much you are following or not, that would be a great help to me. I can get the feedback and teach at that level. So I am just waiting for you to come back and routine regular work to start. So going back to the subject of discussion today, anesthesia for cardiac catheterization. Since the lecture is not very long, I have been correcting the university papers last few days. I am very happy if you read 2 pages only, but relevant thing, rather than writing most useless things. Don't aim to fill up the pages, that wastes your time and you don't get the good marks. So the highest marks I have given is to one paper where one candidate wrote only 2 pages about a topic. So he gets about 7 or 8 out of 10. So don't think of like I tie an IBP here or put a pulse oximeter to this. That's not important. Every lecture, every particular anesthetic management of every particular patient is different depending on that disease. Okay, so now let's go back. So usually my habit is to add a little bit of history to it, because we must always learn from the history so that we progress ahead. So this is an interesting character. The man behind modern cardiac catheterization, he is Werner Frostmann. He was a German. Actually, he was also a Nazi who fought for Germans. He is the one. Why he is very important and why this character is very interesting, I will tell you. So in 1956, somebody called Werner Frostmann, you can see the photograph. Hello, sir, you have been awarded Nobel Prize in Medicine in 1956. He was kind of shocked. For what? He totally forgot what work he has done and for what he is being awarded Nobel Prize. Now when we go to the next slide, we will see it. He is, remember, Werner Frostmann. Many of the quiz masters and the cardiac anesthesia people are very fond of him. So remember this character. He was 25 years old when he did something very unusual and fantastic. This is the X-ray that brought Nobel Prize for him. one X-ray for a Nobel Prize. The title is that. So when I used to conduct the quizzes, I would put this one. This chest X-ray image was taken by Werner Frostman in 1929 to document the position of the ureteric catheter he introduced from his left antecubital. The fellow, look at his guts, he cannulated himself, left cubital fossa, a ureteric catheter, and which went into his right atrium, right auricle, so that you can visualize what is happening inside the heart. So if you just go back to the history till 1500s, nobody knew about the circulation. Nobody knew. People used to think that the blood comes from inside to outside. The difference between arteries, veins, everything, nothing was known that time. So then progressively we came to know, because of William Harvey, we came to know about circulation. Then how the blood circulates within the body. Even he did not know about the capillary circulation, which was later demonstrated by somebody by examining microscopically the frog's heart. The capillaries they came to know. So William Harvey differentiated into veins and arteries. So this is important for us. Why I am telling this, giving you background is, this is a bit interesting. This fellow was told not to do this kind of very heroics. It's a very, very dangerous one, like pushing the catheter. You know what happens? The chance of hematoma, infection, and it can trigger arrhythmia. You know what he did? He took the help of a nurse and he did not tell her what he is going to do. Inserted cannula. Then when she threatened to report the matter, he tied her, went to the radiology department all by himself with the catheter inside his heart. Downstairs he went and then had himself X-ray. Then he had shown it to his boss. Although the paper was published, and till then nobody knew what exactly happens, what are the chambers of the heart, any cardiac anomalies are there. Now today this is the gold standard for all the cardiologists. So you know about the chambers, you know about the pressures, the oxygen saturation, etc. So this is an interesting story of Werner Frostman. Then what do you think has happened? He was sacked. He was sacked and was dismissed, and he had to work in the urology department as a very junior person. In 56, after several years, along with two other people in physiology and medicine, he was awarded Nobel Prize. So this is an interesting thing. So since the topic is quite small, I am just telling you to motivate you people. The subsequent, now what exactly is cardiac catheterization? Placement of transvenous or transarterial catheter into the heart and great vessels that allows determination of cardiac anatomy, the ventricular function, the valvular anatomy, the coronary and the pulmonary vasculature. So previously in the history they used to call pulmonary circulation as a smaller circulation, and the bigger circulation is a systemic one. So the differentiation came subsequently. So this is one thing. Cardiac catheterization gives you a clue about the heart, it gives a clue about the valve. If there is any gross anomaly, anatomical anomalies, you would know the septal defects or whatever it is, complex cardiac anatomical variations, everything you would know by cardiac catheterization. It's still a gold standard. It is an invasive procedure. The problem with cardiac catheterization is it's much safer now. You do through the transradial also, many people do, because the easier way you can stop the bleeding by pressing it. So, but most people technically it's easier to do through the femoral route. So most people do through the femoral route. So it is an invasive procedure. The pressure measurements in the chambers, the blood sampling for oxygen saturation can be made from the chambers and great vessels, which helps us to know the degree and the sites of shunt. Where exactly shunting is occurring? Where exactly is the defect? What do we mean by shunt? Shunt means admixture of venous blood into the arterial blood. Usually the pressures being more on the left side, what happens? The blood is pushed to the right side, which is desaturated. But when you do cardiac catheterization, you suddenly find that there is more oxygen saturation than you expect. That means there is a admixture, right to left or left to right. So similarly, when they depending on the pulmonary resistance, etc., the shunt could be from the opposite direction. The venous admixture could occur on the left side, and the left heart side they will have less saturation because of venous admixture. So which helps us to know the degree and sites of shunt, and also helps us to measure cardiac output by dye indicator method. So this is still a gold standard. Today when we talk about the cardiac output measurements etc., the fixed principle is taken as a basis by which cardiac output is measured. Now you have many methods, invasive, non-invasive etc., but the first description of cardiac output was by a dye indicator. You do a distal sampling. For example, an organ is perfused, a kidney. You afferent you sampling you do and efferent sampling you do, and that's how you calculate the flow. This depends on the fixed principle. This is one thing again you should remember. One of the few equations which you should always remember: a shunt equation, fixed equation, alveolar gas equation. That I will tell you. I have always been repeating this one, right? So it helps in knowing the cardiac output. So this is an important diagram you should always remember. So it gives you entire picture. Now you see that the systolic and diastolic pressure relations are given in blue. The pressures are given in blue and oxygen saturation are given in white. Now you see, so our seniors, when we were students, this is one of the very pet questions of all the examiners. What are the different pressures in different chambers and different grade vases? So let's come to the right atrium first. The pressure is 0 to 4 millimeters of mercury. When it comes to ventricle, it is both systolic and diastolic dictate, 20 by 0 to 4, and the diastolic is 0 to 4. Then when it comes to left atrium, it is 6 to 8, and when it comes to left ventricle and subsequently aorta, it is 105. In a young fellow, 105 to, and diastolic is 0 to 5 millimeters of mercury. This you have to by heart. So this is one of the very pet questions. This is very important for us to explain all the cardiac physiology. So some of you might in future become cardiac anesthesiologists. So this is very important. Now coming to saturation. So by the time the blood returns to right atrium, what happens? It is 75%, you can see. But when you see at the lower end of the atrium, right atrium, it is slightly less because the inferior vena cava joins there from draining from the intestines etc. So it's much more desaturated. If you take an average, it is 72%. So when it comes to ventricle, same blood comes 72%. But when it goes to pulmonary artery, still it is 72%. The same blood is pumped out. You have seen this pulmonary pressure is 20 by 10. Usually we take it as 50 millimeters of mercury because 15 millimeters of 14 to 15, because you grade pulmonary hypertension depending on the magnitude of the pressures. So we call it a severe pulmonary hypertension when it exceeds 50 millimeters of mercury. This has a lot of physiological importance. So normally it is 20 by 10. The saturation is 72%. Now let's go to the right atrium, left atrium, sorry. So the pressure is 6 to 8 millimeters of mercury, but the saturation is 100%. It is coming fresh from the lungs. Then when it comes to left ventricle, there is slight venous admixture, anatomical shunt etc. It is 98%. Aorta also, it's more or less same, 98%. This is how it is delivered. So you must know the pressures, you must know the saturation. Supposing let us see if there is an ASD there. What happens? The blood flows from left to the right or right to the left? From left to right it comes because the pressures are more. So what happens? The saturation are more than expected. It will be 90 or 85 like that because from left atrium it is coming into the right atrium. So that is how the sampling is done. This is important because when we talk about the anesthesia part, you will realize that this is an important issue. So what are the anesthetic issues related to cardiac anesthesia for cardiac catheterization? The first one is, this is one of those situations where anesthesia had to be administered or anesthetic services are required remote from the operation theatres. They are usually dark, congested and less help, less trained people in your field. Maybe there are cardiac technicians are there, radiology technicians are there, but hardly anybody to help you. So we used to realize, we used to feel quite tensed up because if something goes wrong there, you don't have much help. So this is one of those places where anesthesia or anesthetic services are needed outside OT. The others are MRI suite, the cardiac catheterization lab, CTs. Small child is coming and they want the child to be immobile, then you have to give administration or you have to administer sedation etc. Then also for radiotherapy it is required. So many other places where sometimes for any angiographies etc. So our anesthetic services are required. So the first problem in anesthesia for cardiac catheterization is it is removed from the main OTs, number one. Second, patient is not easily accessible. See, as I told you, a lot of people are moving around, who are not of much help to you, but you don't get real good help. Then there is fluoroscopy. Fluoroscopy causes more radiation, significant exposure to radiation compared with your C-arm, etc. Always the fluoroscopy gives more radiation. The duration may range from 30 minutes to, on an average, to 2 to 3 hours, supposing they decide to do on a procedure. For example, they want to do coronary angiography. So always remember, when you want to visualize the right side of the heart, you do a transvenous catheterization. When you want to visualize the left side of the heart, it's transarterial, right? So similarly, depending on the necessity, the duration extends. For example, left side they want to do coronary angiography, then they suddenly find that 99% block is there. They may do even stenting also, or angioplasty. So these kind of things keep happening in cardiac catheterization lab. So you must be prepared for everything from half an hour to 2 to 3 hours, depending on the procedure. Age of the patient varies from neonates to elderly. So this is important. Neonates, they have to do cardiac catheterization to know the complexity of the cardiac anomaly. So many of them are premature, cyanotic, and with multiple comorbid conditions. Right heart catheterization for right side chambers, as I told you just now, and left side through the left femoral artery. Usually it is done, and if they do through the femoral vein, right femoral vein is done usually for the right heart catheterization. So they can do through the left femoral also, but usually they do for arterial. Usually they choose the left one for this one, because this is more or less a straight line. The first right heart catheterization was performed by Bernard Postman. We discussed. So this already discussed. So although the cardiac echo diagnoses many anomalies non-invasively, cardiac catheterization remains the gold standard for correct diagnosis. What are the anesthetic issues? Other anesthetic issues. One is, I said, it's away, and second is you have patients ranging from a neonate to an old patient, etc. And then the problems with the vascular cannulations. It may be hematoma, or sometimes it may cause severe bleeding, etc. So that is another issue. Then embolism can occur. As catheter has to pass through the chambers, arrhythmias can occur, ranging from simple ectopics to hemodynamic disturbances. Then the other issue is the arrhythmias is one issue, and then it can cause hemodynamic disturbances. Suddenly, if there is a fibrillation, the BP falls. The heart blocks can occur, even cardiac arrest can occur. Vascular injuries can cause bleeding and embolism, as I told you earlier. Then another important thing is you have to maintain steady hemodynamic state, because your idea is during cardiac catheterization to know the pressures. Supposing you have to use very powerful inotropic, etc. There is any low cardiac output, etc. Then the purpose is gone, isn't it? So the patient has to be reasonably stable hemodynamically, and then carbon dioxide tension and arterial oxygen tension must be normal. This is very important again. Supposing you have given 100% oxygen, what will happen? The arterial oxygen tension will raise, both in the right chamber also, right atrium, etc., or pulmonary arteries also. So your idea is gone, isn't it? You want to know whether there is overriding of the vessels or there is any septal defect, etc. If the saturations are disturbed by you are giving 100% oxygen, then there will be a disadvantage. So you have to maintain the FiO2 as low as possible. FiO2 means the administered inspired oxygen concentration should be near normal. Sometimes if the otherwise patient is normal, you can do just a normal air also, or keep it less than 0.25. Normally it is 0.21 atmospheric air. You can maintain around 0.25. It becomes difficult, particularly when pulmonary vasculature is being studied. You want to measure the pulmonary vascular resistance. So then supposing the patient is acidotic or hypoxic or hypercapnic, what happens? Pulmonary arterial hypertension increases. So you don't get the correct picture. So you have to maintain the patient free from hypoxia, hypercapnia and acidosis. So these things you have to keep in mind. These are the issues in administration of anesthesia. Then what are the anesthetic options you have? Most procedures in adults and grown-up children are done under sedation and local anesthesia. That's adequate. If the patient is willing or can be still remain still during the procedure, that's good enough. So you administer generous local anesthesia and also give sedation. What are the sedatives we give? Fentanyl, midazolam are usually administered. Sometimes even oral midazolam is also given, as this causes minimum hemodynamic distress. Propofol, etomidate, dexmedetomidine have also been used. Ketamine in low doses is used by some people, but the fear of increased oxygen consumption and tachycardia. So these days, with the advent of the other drugs like propofol, which gives good sedation, etc., the local anesthetic, the ketamine is slowly going out of. So when we were students, nitrous oxide and oxygen, Antonax, what we call 50%, 50% each with the local anesthesia was sufficient. So now ketamine also is described. Some people still use it, but slowly it is going out of shelf. See, the maintaining oxygen, what is normal for the patient, more if need arises only. Like if the patient is becoming desaturated, then you may have to give more. Then the patient safety becomes more important, not the procedure. So when sampling is done, FiO2 should be around 0.25, as I said earlier. This is important, pediatric cardiac catheterization. This is one segment of patient who will give you a lot of problems. Important considerations are ranging from premature neonates to grown-up children. The congenital heart disease, which may be cyanotic or septal defects or complex anomalies. Patients are highly stressful. Not only patient but also the parents are highly stressful, and maybe both the patient and the relatives are less cooperative. They are having their own problems, so they are worried all the time. They may not cooperate with you fully. Non-cardiac anomalies may also be present in this patient. Procedure may also need to be performed as an emergency. Sometimes you have to do an urgent cardiac catheterization, do the procedure if the child is deteriorating fast. The initial echocardiography in these patients may give you some clues, but the catheter-based interventions will be needed. One advantage is if already echo is done, so you get an idea, some idea that this is something is wrong with this patient. This could be the problem. But again, another disadvantage is interventions. The surgeon may also want to do an intervention, like they are doing ballooning or tight mitral pulmonary stenosis is there. They may want to do balloon valvuloplasty, etc. So it may have to be done as an emergency. These patients are particularly premature and are very sensitive to sedatives and narcotics. This you should remember. If you give too much of fentanyl, etc., they become hypoxic. You have to give more oxygen. Then again, hypoxia makes pulmonary vascular resistance to go up. So all these problems would come. So you have to balance the sedation, etc. Many are in low cardiac output states, and metabolic acidosis is common in these patients. Sometimes pre-procedure ABG is needed. But one advantage during cardiac catheterization, since they are already doing arterial catheterization, there is a point of time instruments are present which will give you immediate ABG on the table also, because arterial cannulation is done in labs like that. The other problems are like hypoglycemia, hypocalcemia and hypothermia. These are all very common, and blood loss is also an important one, particularly in premature babies. They are so small and blood volume is so less. Need good post-operative analgesia. So these are the issues when it comes to cardiac catheterization. If the patients are older, the local anesthesia and good sedation is adequate. Pre-medication with midazolam 0.5 milligrams per kg is useful. Even cyanotic patients, oxygen is administered if it falls below a base level. For example, from the beginning the patient has been having a saturation of, let us say, about 90% or like that. You maintain it at that level, or you don't try to increase it to 100%, but because it interferes with your diagnosis. The idea is to avoid fluctuations in pulmonary vascular resistance. Fentanyl, midazolam, propofol are widely used. As I told you, ketamine is sometimes used, particularly in pediatric patients, but may increase oxygen consumption. General anesthesia may be needed in problematic and premature babies. The babies are quickly becoming apneic during your sedation, etc. Then, or they are having multiple problems. It may be the general anesthesia may be needed. It is found that the diagnostic accuracy is not altered with proper general anesthesia. So, over time, it has been found. Now that you have better agent. Previously, when we were all students, the sevoflurane was not easily available, and we did not have propofol so easily. So, it was different. Now they say that if you have good inhalation agent like sevoflurane, it's okay, and oxygen, little bit of nitrous oxide, and nitrous oxide also when some people don't use it, oxygen and sevoflurane they use with along with local anesthesia, and non-depolarizing muscle relaxants are used. Usually atropurium is used. So they say that a good general anesthesia, keeping in mind not to give too much of oxygen, FiO2 should not be more than 0.25 etc. Then you can give general anesthesia. Capnography is must to maintain normal ventilation. Remember that there is actually a definition of respiration which says that body adjusts the respiration to maintain carbon dioxide at a near normal levels. So capnography is important for us because it gives you a clue about the circulation. It also gives clue about the pulmonary ventilation, alveolar ventilation. So FiO2 is kept low, even just air is sufficient, particularly when blood is being aspirated to measure saturation. At that particular point of time, reduce the FiO2 or even give normal air. If child is slightly grown up, you can try T1, total intravenous anesthesia with narcotics in selected patients. In addition to diagnostic cardiac catheterization, interventions may be planned in cath lab, as I told you earlier, such as coronary angiography, stenting, angioplasty. Usually it is an elective procedure. These patients need more extensive evaluation. The procedure is also contemplated. The surgeon will tell you in advance. So, in your pre-anesthetic evaluation only, you spend more time evaluating the problem. Monitoring and longer duration of anesthesia is needed in these patients. So with that, I am concluding this lecture. So what I wanted to tell you is that these kind of topics are they are surprise questions in your examinations. But in practical life, those of you who have worked in between your MBBS and MD, worked outside, you will know that sometimes patients are sent for CT scan and there the child is moving, you need to give sedation. So these in practice these are quite normal. And not only in practice, when you go to, when I was working in Karnal Medical College, MRI we had to go regularly. So MRI is associated with even more issues. The issues of magnetism, everything, so many other issues are there. So everywhere radiation problem is there. In radiotherapy, sometimes they put radioactive materials, etc. under anesthesia. If you go to LV Prasad, all OP patients, examination under anesthesia, premature babies, premature cataracts, etc. All these things, they take anesthesia service. So don't think that this is a rare question. In cath lab, again one experience I had is I just went to watch and then I ended up anesthetizing the patient. They wanted to do cerebellar artery aneurysm, they wanted to do embolization. So you have to go through the femur. So when we were students, the aneurysm clipping used to take for 10 hours, 8 to 10 hours like that. Now within 1 hour to transfemoral artery, they go to the circle of the vertebral artery, etc. Then they embolize it. So now some parents came actually asking me about the prospects in anesthesia, etc. We are there everywhere. We are omnipotent. We are there in cath lab, we are there in MRI, we are there in intensive care, we are there everywhere. So you would be expected to know about all the field, about cardiology, about respiratory, pulmonology, because in the theatre you are everything. So with this I conclude the lecture, and I will take the day after tomorrow for the juniors. So my advice is all of you attend all the lectures so that it becomes a revision for you. So these things it may not be kept in YouTube for a long time. I am just warning you right now. Don't think that I will read at the time of examination. You have to, your examination preparation start from the day you join the department. So okay, but I want all of you to respond so that I give you attendance based Not that you have attended in the beginning and again you come at the end. It's not like that. You are all grown up now. You have to take more interest from the beginning only. So this kind of things, it would take you lot. It will you have to put lot of effort to prepare these small lectures. So if you listen to me carefully, if you read the few things like cardiac catheterization, why it is done, who has done it for the first time, and then what are the anesthetic issues, and how does it help us evaluate the patient. So you will know where exactly is the shunt, where exactly is the septal defect. As I have told you, upper part in the atria, supposing the ASD is at the upper level or at the lower level, you will know depending on the saturation. So you get a lot of information from cardiac catheterization. So we also play an important role. Okay, then. Okay, I told you our plan is we will take more and more classes now that we are little free, more lectures we are taking, but in future we will be asking the seniors to present the seminars. Okay, thank you very much for your time. So you can give your attendance by feedback. I will note it down. Thank you. పక్కన చెప్తామా క్లోజ్ చేసుకుంటాం అర్థమైందా మీకు అర్థమైందంటే వాళ్ళందరికీ అర్థమైంది ఇవన్నీ ఏంటంటే బుక్స్లో మెన్షన్ చేయరు అక్కడ ఉంటాయి ఎక్కడో దొరకకూడదు మెయిన్ గ్రూప్ ఈజ్ మిల్లర్ ఇస్ ద ఎక్స్టెన్స్ అందులో అది రెఫరెన్స్ బట్ ఆర్గానిజేషన్ బయట ఒక బుక్ నేను యూట్యూబ్లో లెక్కలు